Hello everybody, I'm Bronwyn from PACOP and today we are looking at the RUG-ADL. The RUG-ADL's other name is Resource Utilization Group Activities of Daily Living. It's one of the 6 tools that we use in PACOP. The RUG-ADL is used in the profile collection in routine resident assessments every 3 months and in the outcomes collection when a resident is being monitored for end-of-life changes and it identifies their palliative care needs. Very good tool to assess resources required. The RUG-ADL assessment tool is clinician rated. It measures 4 activities of daily living. These activities of daily living are considered to be hierarchical, which means to say that they are of the first things that we learn when we're young, and they are of the last things that we lose as we reach the end of our lives. This means that the RUG-ADL is a very useful monitoring tool because it helps to identify changes that suggest end of life and therefore increased palliative care needs. The important thing to say about the scoring for the RUG-ADL is that it's the total score we're looking for. The 4 activities of daily living are bed mobility, toileting, transfers, and eating. Effectively, if you are not able to move yourself in bed, not able to toilet yourself, not able to transfer yourself, and not able to feed yourself, it is an indication that you have a lot of risks around malnutrition, falling, skin-associated damage because of incontinence, risks of constipation, potential sepsis, and from a bed mobility perspective, you become at increased risk of developing pressure injuries. So with each of these activities of daily living scored independently and then added up to give you a total score, what you will be able to see is the current level of dependence that the resident has on staff and their equipment requirements to be able to care for them. It also will give you an idea of the current physical abilities and needs in relationship to those 4 activities of daily living. It also speaks to what the resident is actually able to do at the time of their assessments. Many residents will say they can do things, and they may be able to do them, but they don't do them. So it does then mean that the staff are having to do that for the resident, and that is about resource use. So this is what the resident is actually doing at the time of assessment. And a good question to ask yourself is, how much staff assistance is required to maintain this resident's physical care regarding these 4 activities of daily living? This is the scoring matrix for the RUG-ADL. You will need to do each one of these activities of daily living separately, scoring them separately. On the left-hand side, you have bed mobility, toileting, and transfers, and on the right-hand side, you have eating. If a person is scoring 1 in any of those categories, it tells us that that person is independent. They may have continence aids, they may require assistance from a mobility aid like a frame to be able to transfer. They may have difficulty moving up in bed, but they can actually do that on their own. They may have complex food needs like modified diets, peg feeds, nasogastric tube feeds, but they can do all of that on their own. If that is happening, the person will score 1. There will always be a 4 score, never a 0 score. So there'll never be a 0 score in RUG-ADL. The lowest score that you can get is a 4. And anyone with a 4 score is an independent person. When you look at the score of 2, it's only relevant in eating, and it indicates limited assistance required. So this person is going to need hands-on assistance, opening packets, cutting up their food, requiring modified diet. Could be that you're organizing how their meal is prepared, presented to them, set up in front of them, so that they're not overwhelmed, and you're giving them their main meal first and their dessert second, so that it makes sure that the person has a very pleasurable eating experience and that they are actually finishing their meals. When you get to the score of 3 in eating, this is extensive assistance required. So the person requires someone to sit with them the whole time whilst they're being fed, because if there isn't that assistance, the person would not eat. If the person's having tube feeding or nasogastric tube feeding, then they will also need someone to be doing that for them the whole time, and it's a maximum level of care given. That will score 3. 3 in the context of bed mobility, toileting, and transfers indicates that there is 1 person required to be able to finish or achieve these activities of daily living for the resident. When you're scoring 4, it says there that it's less than 2 physically assisting, and what that really means is it's 1 staff member and it's equipment. So that equipment could be a hoist, it could be in the context of toileting catheters, bedpans, urinals, giving suppositories or enemas. With transfers, it could be using a stand-up lifter. It could even be moving the resident in a wheelchair to get from one place to the other, or a commode. All of that is 1 person doing that job with a piece of equipment, and that's a score of 4. When you get to the score of 5, then this means that there will always be 2 people physically assisting. It may be that you have equipment involved, but the point here is 2 people. When you're scoring 4, it's 1 person and equipment. When you're scoring 3, it's 1 person. But when you're scoring 5, it's 2 people or more physically assisting in all of those particular care needs. Could be adjusting the person in bed, providing pressure injury care, doing skin care, managing bladder and bowels, and usually there's limited transfers at that time because the person is mostly bedbound. So having scored each one of those activities of daily living, as you can see in the square there, you will then add all of those scores up and have a total score. The interpretation of the total score is as on the left-hand side in that table. Total scores of between 4 and 5 indicate independence, but because they're in your care, they obviously need monitoring. A person who scores between 6 and 13 usually requires the assistance of 1 person. A score of between 14 and 17 is the assistance of 1 person and equipment, and a total score of 18 is indicative that the person requires assistance of 2 people for all care. We become very interested in the scores after 14 because that then is telling us that there are some significant changes happening to the resident. So the key points about the RUG-ADL is that it rates what the resident is actually doing and therefore the support that they actually need to manage their activities of daily living. Therefore, it measures all the resource requirements that are happening in your facility around people and equipment required to meet those activities of daily living and care needs of the resident. The other thing that we see, and the RUG-ADL works very closely with, is the Australia-Karnofsky Performance Scale. So this is also used in the Profile Collection and the Outcomes Collection, and the 2 of them together provide a comprehensive functional assessment. The RUG-ADL looks at the functional status and the support that the person actually needs, and the AKPS is a performance scale showing how the resident performs in their daily living. So the 2 together have a very good overview of the resident's functional status. So this brings us to the end of the RUG-ADL Clinical Bite. Please be sure to check out our other PACOP Clinical Bites. And for more detailed information on any of the PACOP assessment tools, please speak to us or send us an email, and the email is on this link. Lovely to chat to you. Bye.